So some definitions and propositions. The total benefit of a treatment is the outcome of a treatment for a given population versus no treatment, the latter almost always zero cost. And I put that down there not only to make sure everybody knows what we're talking about, but also because I think a lot of the political discussion of comparative effectiveness analysis was framed, I think incorrectly, more in terms of total benefit. It was the idea, based in part on the Dartmouth analysis and in part on what politicians desperately want to believe, that there's just so much waste out there that if we just stopped doing it, which of course would mean cost would go down to zero, it wouldn't do any harm and it might even do some good. So to some extent, the comparative effectiveness research, I think, is not going to be primarily directed at that kind of measure, and may disappoint some people for that reason. Instead, comparative effectiveness research is primarily devoted toward trying to get better measures of incremental benefit, difference in outcome from treatment X versus treatment Y. And so probably telling everybody things they already know, but that's what I interpret it to be. And in some ways, the criticism of existing analyses of benefits from health care, especially when done by profit-seeking firms trying to justify their product, was they often compared it with either no treatment or standard care and not with the next best treatment. So the idea here would in part be to compare it with the next best treatment. At the risk of piling on, I will say kind of what Alan said. I'm glad he said it, that it's not obvious that if we get better information of this sort than we now have about the benefit from treatment X versus treatment Y, that we will find that the more effective treatment has a lower cost than the less effective treatment. It could well go the other way. So the CBO, I think, despite the fact that they were, of course, also thinking of a world with no teeth, but even so, even in a world with teeth, of course, if you only implement the teeth for the cases of cost reduction and not for cases of cost increase, it may work out differently. But if you used, we won't know till we get there, but if you use the results of comparative effectiveness research to always support the better treatment, which I think is what a lot of people have in mind and kind of what the citizens probably want, that may actually end up increasing cost rather than reducing it, although my best guess is it probably won't make much of a difference one way or another. So I just wanted to say that. There will be some more worries on that score, though, at the end of my remarks. This is partly based on reading some of Alan's work and partly based on what we did. It was pretty rare to deny coverage, but when it happened, it wasn't because of greed or evil doing. It was almost always because, I put almost always because I'm an economist and maybe there was some other story, but almost always because of the absence of evidence of incremental benefits. So you just, if there's something that doesn't seem to provide any additional benefit, that could be a reason not to pay for it. But it is not true for this insurer or for insurers in general that the reverse proposition holds, that when there's an absence of evidence of incremental benefits, insurers almost always deny coverage. Instead, most of the time, they'll pay for what the patient and the doctor agree on, even in the absence of evidence. So the practice out there, I guess now, and I anticipate practice at least for the foreseeable future, is not going to kind of wade in and maybe do the Republicans' worst nightmare of denying coverage when there's an absence of benefit. And one reason to worry about that, in addition to being a Republican, is you may worry that the absence of evidence is not equivalent to the evidence of no benefit. And if you have a big enough sample size, you can almost always find a difference in the effect of one treatment rather than another that's statistically significant. Usually if you find no statistically significant difference, it's because your sample size is bigger. It's sort of, at least I tell my PhD students, if you've got one of these huge samples, we really even shouldn't pay much attention to statistical significance because it's more or less a foregone conclusion that everything will be significant statistically. It's just whether it matters practically or, I suppose, by extension here, clinically.